Hello guys, I am Dr. Amrit Nasta and today I want to discuss with you the questions that I had posted on Telegram and the results and a little bit about how to solve these kind of questions. I was quite surprised by the results that I got in the poll on the Telegram questions. So let's begin with the first one. Most of these questions are from GIT and trust me, they are very standard questions and I will show you the responses that people have given also. So it will give you an idea of how people think, how you should not be thinking and the correct way to solve these kind of topics, right? So let's start with the first one. Such an easy question, still so many people got it wrong. Which of these is not a significant mechanism in preventing GERD? Now, why does someone get GERD? There are a lot of reasons. I'll put it in a simple way. The thinking is the main mechanism to prevent gastroesophageal reflux is this lower esophageal sphincter. But mind you, that's a physiological sphincter. It has a small role, but yes, it does have. So this is correct. But more than that, there is an angle over here. That is the angle of his or the angle at the G junction between the lower esophagus and the fundus. This is called angle of his. Of course, this is a mechanism for preventing reflux. Another important mechanism is a lot of the esophagus is in the thorax, but there is some esophagus which is in the abdomen also. That is called the intra-abdominal length of esophagus, this part. The intra-abdominal, the part which is below the diaphragm, that also prevents GERD. But what does not prevent GERD is intra-abdominal pressure. As the intra-abdominal pressure will increase, it will compress the stomach and push things more. This will worsen GERD. So I'm sure many of us would have studied factors preventing GERD, but when given a question, we often make a mistake. You can see 48% got it right. So that's not very good. These kind of questions are very straightforward. Little bit of practice and you will get them right. Okay, another very straightforward question. Which of these is not a risk factor for squamous cell carcinoma of esophagus? Now, what Bailey tells us is squamous cell carcinoma is more common in India and in the Western world, it is adenocarcinoma. That is what Bailey tells us. So, squamous cell carcinoma happens whenever there is irritation to the esophagus, chronic irritation, or Kelly-Patterson syndrome. This is correct. Corrosive injury is correct. In achalasia, the proximal part, proximal to the achalasia or proximal to the tight LES, gets irritated because of stagnancy of food. But even if you didn't know all this, Barrett's esophagus, come on, it causes adenocarcinoma, right? Because Barrett's esophagus is a columnar metaplasia, so it will give you adenocarcinoma. Simple question, 50% people got it wrong. So what I'm trying to tell you is, it's not important that you study hi-fi things if you can't get these right. Let's move on. Little tough question, but as you can see, 67% got it wrong. Okay, 67% got it wrong means two-thirds got it wrong. Identify the mismatch in approaches for esophagectomy. Now I'll tell you very simple. In surgery, as an MBBS student or for NEET PG, you need to know only two approaches. Esophagus is in the neck, it's in the thorax, and it's in the abdomen. So if I have to do a surgery for esophageal cancer, I may have to remove all the esophagus from these three areas. So what are the ways in which I can access the esophagus? You need to know only two. They are the more important ones because students often ask me, sir, this is a very tough question. Bailey says so many things. How much do you remember? I'll put it in a very simple way. Esophagus in the neck lies on the left side, cervical esophagus. Then it is retrosternal, thoracic esophagus, and then there is a little part intra-abdominal. So when I have to do esophagectomy for cancer, I usually use one of the two approaches. One approach, the very commonly used approach, is called Ivor-Lewis, where I take one incision on the abdomen and I take one incision on the right thorax. So it is a thoraco-abdominal, but two incisions. Abdominal incision is separate and right thorax is the other side because it's easier to access. Left side you have heart, so little harder to access the esophagus from the left. Right side there is no heart. You can easily reach, you can go beyond the lungs and reach the esophagus. So you take a right thoracic incision. So Ivor-Lewis is abdomen plus right thorax. But if I also want to remove the esophagus in the neck, I will also take an incision in addition on the left side of the neck. That is called McKeown or triple approach. That is McKeown or triple approach. Abdomen, right thorax, left neck. And here, what have I given? I have given you right neck. So simply put, you should have just seen it and said, okay, it's not right neck, it is left neck. And that becomes the incorrect or the mismatch. Oringer is also called as transhiatal, but I don't feel you need to worry about this one, transhiatal. Okay, this was a little tricky one, but yeah, only 13% people thought it was a mismatch, so that's fine. But 67% thought all are correctly matched. Come on, you got this simple wrong. This topic is being asked very frequently in the last few NEET PG exams. They are asking about corrosive injuries, esophageal perforation. So they are good to know. There is not too much you need to know as a student. You only need to know if there is a perforation, why did it happen? Usually it happens, or the most common reason is instrumental trauma. All right. Like I was doing endoscopy and during dilation of a stricture, it got perforated. I overdilated it. Or there was some narrowings and I tried to push the endoscope and it got perforated. Most commonly it is instrumental, but it can also happen in a disease called as Boerhaave syndrome. And what is Boerhaave? Boerhaave is spontaneous esophageal perforation, right? Boerhaave is spontaneous esophageal perforation. Why will esophagus perforate spontaneously? Now, this is a disease where someone has a lot of vomiting and if he's intoxicated. So what will happen is he vomits, but he's intoxicated. So the cricopharynx does not relax. The epiglottis does not open. The cricopharynx does not relax. So the esophagus has a very high pressure inside it and it bursts. Where does it burst? Normally, it bursts on the left lower wall. Okay, the left lower wall of the esophagus. That's what ruptured, right? So that is a common site. Now, the question is asking, which one will you operate? Which one will you conserve? So let me tell you which one will you conserve. That is given in the options, obviously. So you will conserve sterile perforations. Okay, where there is not much contamination. You will conserve instrumental perforations. Because instrumental means it will usually be sterile. Okay, and the person should be stable. So which will you operate? That is the question. Which will you not conserve? Which will you operate? Obviously, the one which you will operate is if the person is very septic. So there is too much contamination, there is a high septic load. Or if it is a Boerhaave perforation, because in Boerhaave, obviously there will be a lot of septic load because the esophagus fills with the gastric contents and then it bursts. So a lot of things will leak out. You can't wait in this patient. He will get mediastinitis, right? And the third is abdominal perforations because there is a very high risk of peritonitis. So simply put, septic load, Boerhaave perforations, unstable patients, or intra-abdominal perforations for whatever etiology you are going to operate, right? So that is what you need to know in this question. So let's move on. A factual question which every student must know is risk of adenocarcinoma in Barrett's. Okay, so there are three values that you must know. The first value is if the person has Barrett's esophagus, but there is no dysplasia. I mean, there is only a metaplasia, there is no dysplasia, which is what the question was asking. The annual risk of cancer is 0.2 to 0.5%. If there is Barrett's esophagus and there is a low grade dysplasia, so Barrett's with low grade dysplasia means now there is some risk of cancer. The risk annually is 0.7%. And obviously, there can be Barrett's with high grade dysplasia. The risk is going to be 7% per year. All right. Again, see how many percent people got the answer correct. Only 14%. So you have to get these questions right. These are not the most difficult questions. The most difficult questions, if you leave or get them wrong, is fine, but unpardonable to get these wrong. Again, straightforward question. Just see how many people got it wrong. How many people got it right. Most common site of Mallory we stare. This is a line from Bailey. Now, what is Mallory-Weiss stare is if I am intoxicated and I vomit a lot, sometimes the mucosa tears over here. The mucosa will tear. Now, this is not Bohr-Haff. In Bohr-Haff, there is a perforation. In Mallory-Weiss, there is a tear. Tear means only mucosa will tear. So the mucosa tears, and there is a submucosal bleed. So the submucosal veins will bleed, and that will give you hematemesis or upper GI bleed. That is Mallory-Weiss tear. It happens typically at the gastric cardia. Okay, if this is not given in the option, the next best answer would be GE junction. Okay, third answer will be esophagus. Okay, so the best answer is cardia. Next best answer will be GE junction. Okay, because that's where it tears, but it's on the cardiac side of the GE junction, and it is a self-limiting submucosal bleed. Normally, the bleeding stops by itself. Very nice question. This has come in FMGE exam very recently, last to last year. So which of these procedures provide maximum acid lowering effect in peptic ulcer disease? And this is there in a table which I have shared here. This table is in Bailey. Now you will be like, sir, how can we rectify a table from Bailey? You don't need to do it. You need to apply some concepts and some common sense. It's not the most difficult thing in the world. Common sense is difficult. I believe it's easier to mug than to use common sense, but the habit has to form because there is only so much you can do. At least in clinical subjects, at least use common sense. So when I do procedures for acid lowering, there are two groups of procedures. One are those which are based on vagotomy, right? So when vagus is cut, the acid production from or the acid release from the stomach will reduce. That is vagotomy because vagus controls acid. The second group of procedures are where I resect the antrum. So they are based on antrectomy. They are resectional procedures. Because antrum is from where you produce maximum gastrin. And gastrin will produce gastric acid. So if I cut the antrum out, then gastrin will reduce, acid will reduce. That is a principle. So which will be the most efficacious procedure will be a combination. So the answer here is going to be vagotomy with antrectomy. Only 1/3 people got it right. See this table, now it will make sense. Vagotomy with antrectomy. Risk of recurrent ulceration is less than 1%. In all the others, it is more than 1%. Right? So if you use the concepts, the fundamentals, you will not make a mistake. So this is one part. But the problem is side effects are also very high. So I can offer this to the patient, but he will be miserable. His acid production will reduce, peptic ulcers will heal, but he will be miserable. So if they ask you best tolerated or least side effects, answer will be highly selective vagotomy. Little high recurrent ulceration, little high, but best tolerated procedure. This is going to be highly selective vagotomy. Okay, please remember this one, best tolerated or least side effects. And such is life. The more aggressive we are, the more we may be successful, but we will also cause harm. So when we are studying, if we shut out everyone from the world, we no social media, everything, we just stop, no family contact, no social contact, only study very aggressively. You may get a good rank, but you will also ruin your interpersonal relationships. So you will lose your friends, you will lose your family because for 1 or 2 years you will be absolutely closed. So more the aggression, more the side effects. But if you do a mix of both, you study also, but you have a little bit of a social life. It's good, right? So you may not get the best result, but you will also keep your relationships intact. This is my belief, but you are free to do as you wish. This was the only question where the result was good. Not true about congenital tracheoesophageal fistula. So associated with ventricular septal defects. This is true. In fact, cardiac abnormalities are very commonly associated because they are coming in the group of what are called as vectoral. Right? You may have heard of this vectoral group of abnormalities. So vertebral, anorectal malformations, cardiac. T is tracheoesophageal fistula, which is in the question. R is renal. And L is limb abnormalities like absent radius. So this is vectoral, which is associated or one of the associations of tracheoesophageal fistula. So VSD is seen, ARM can be seen. Always, yeah, if there is a fistula, it will require surgery. But yeah, fistula between trachea and esophagus is seen in all subtypes. Technically, yes, but there is an exception. I will show you the image that this type, the first type, okay, in this type, there is no fistula. Okay, there is no tracheoesophageal fistula. There is only esophageal atresia. And obviously, most common type is this type C, where there is a proximal atresia and a distal tracheoesophageal fistula. And all of them require surgery. This question is more of intestinal obstruction in neonate. Bishop Coop was done in the past for meconium ileus. Now, what happens in meconium ileus? I will tell you briefly. A child who has cystic fibrosis, who has enzyme deficiencies of the pancreas, when he is born, the meconium pellets get deposited. So the meconium in his GIT does not get absorbed, does not get digested. Because it doesn't get digested, it will form concretions, it will form pellets. And these pellets will go and get stuck at the terminal ileum. So because they are stuck at the terminal ileum, the child is born with an intestinal obstruction. So what they used to do back in the days was they used to disconnect the bowel, and this distal bowel they would bring out as a mucus fistula. Okay, so they would bring it out from the skin like a stoma, and the proximal bowel would be joined, ileocolic anastomosis. But the distal bowel they would bring out as a mucus fistula and they would irrigate it. This was the Bishop Coop procedure, not done anymore. Nowadays, you just do an enterotomy and remove the pellets. You don't do all this fancy Bishop Coop anymore. But it's there in Bailey. Easy question. Only 45% got it right. Not a complication of H. pylori of the antrum. H. pylori is affecting the stomach. H. pylori is going to cause peptic ulcer. Right? It has been implicated in peptic ulcer. It is also implicated in chronic gastritis. So peptic ulcer, chronic gastritis, adenocarcinoma, and even malt lymphoma, also called as maltoma of the stomach. These are all associations of H. pylori. What is not GRD? Come on, GRD has nothing to do with H. pylori. In fact, Bailey gives a line, GRD is supposed to be protected, or H. pylori has a protective effect on GRD. So it will cause peptic ulceration, but conversely, it will reduce acid reflux. Surprising, it is given in Bailey. Again, this was a straightforward question. This line is there in Bailey. Bravo capsule. Bravo capsule is a capsule which is implanted in the lower esophagus for doing a pH manometry or pH study, like how you have 24-hour pH study. When you do a 24-hour pH study, you have to put a catheter from the nose, which goes in the esophagus, and it measures the acid exposure over 24 hours. But the problem is, person has the catheter from his nose like a Riles tube throughout the 24 hours. So it is uncomfortable. To counteract this, there is a capsule. Capsule is implanted in the esophagus. It will record, it will give all the recordings to the transmitter. And after 3 to 4 days, it will dissolve and it will pass out in the stools. So there is no catheter. That is Bravo capsule. So it is used for GRD, gold standard for GRD, like 24-hour pH study, right? Which of the following is incorrect about Zenker's diverticulum? Again, easy question. What is Zenker's diverticulum? You should know there is a muscle in the neck which has two components. So there is a muscle called inferior constrictor, which is in the neck. Okay, so if my esophagus starts here, just above the esophagus is the inferior constrictor, and it has two groups of fibers. One of the fibers are horizontal fibers, and the other group of fibers are oblique fibers, pyropharyngeus, cricopharyngeus. In between these fibers, there is an area of weakness, which is called Killian's dehiscence, from where the mucosa can outpouch posterolaterally, right? Why does this happen? One of the reasons is there is a muscle here at the upper esophagus, cricopharynx. Okay, so there is a cricopharyngeal muscle, and you have inferior constrictor. So if they don't work together in synchrony, means upper one should constrict, lower should open, only then food will pass. But if there is a discoordination between the two, it is possible that upper muscle constricts, lower doesn't open. So there is a high pressure created and the mucosa can outpouch. This will give you mucosal outpouching. If it's mucosa outpouching, it is a false diverticulum. Right? If it's mucosal, it is false. It is because of high pressure. It is a pulsion diverticulum. It is happening because of abnormal motility. It is considered to be a motility disorder of inferior constrictor. Contrast imaging is the diagnostic test. This is also true. Dolman procedure. It is used, no doubt, but it is not a stapled diverticulopexy. Okay. In Dolman, the diverticulum is cut with some energy source like cautery. So there is a diverticulum like this. With the help of endoscope, I cut this wall. That is endoscopic diverticulopexy. I don't use a stapler. And definitely, even if I use a stapler, it will not be a circular stapler. Okay. Staplers used in diverticulopexy are linear staplers. So you had two ways to get the answer correctly. But the problem was why only 17% got it right? Because you have mugged. Dolmen, Zenkers. Dolmen, Zenkers. You have just mugged it up. Dolmen, Zenker. But it is not so. Yes, it is used for Zenkers, but it is not an endoscopic diverticulopexy with a stapler. So diverticulopexy with energy source like a cautery. You can use staplers, but the stapler will be a linear stapler. Diagram is there in Bailey. It's also there in my notes. So you saw the performance of how people have answered on all these polls on my Telegram. I'll be sharing more such videos, but please be very clear. Just watching videos and reading the notes will not solve the problem. You have to solve Q banks and give GTs. You have to practice. Hope you enjoyed this session. Stay tuned for more. Thank you guys and all the best.